tool, this proved and tried and tested tool, more broadly than it currently happens in the healthcare system. I said 2 hours. Well, that's a lot, but you can also say that that's not too much, really, because not too much time, because we have so much to cover. And I will now welcome Professor Maciej Krawczyk, President of the National Board of Physiotherapists. Professor, welcome. I give the floor to you to open the conference. Morning, ladies and gentlemen. I'm very happy to have such a distinguished group of guests here, representative of the Ministry of Health, of the National Social Insurance Institution, of other organizations which are involved in healthcare in Poland. Our guest from WHO, Mr. Nenad Kostanjsek, and from the ICF Research Branch, Professor Jerome Bickenbach. Thank you for the Foundation for Rehabilitation, for their involvement in our project. Briefly, ladies and gentlemen, there are certain ideas which are ahead of their time, which anticipate their time. 20 years ago exactly, in 2001, the Ministry of Health, together with the Center for Organizational Systems in Healthcare, for IT systems in healthcare, organized the first conference at their office at 15 Miodowa Street about ICF. That was immediately after the publication of the material by the WHO. 20 years have passed. We are in a different time now, a different era. We see today how much WHO had been ahead of its times in terms of understanding, in terms of anticipating the needs. And I believe that it is only now, after these 20 years, that we have grown up to this. We have matured to using ICF for the needs of the citizens of our whole world, but also for our Polish general public, for a Polish society. And hopefully this conference will be very fruitful indeed. I do believe that it will. And I do recommend these experts. I give you these excellent experts who work on ICF. So I declare the conference open. Have a good listen and all the best. And thank you very much, Mr. President. I will have the honor in a while, the honor and the pleasure of introducing all the outstanding speakers, including representatives of the WHO. But I just wanted, on a technical note, to give you 2 pieces of information, very important. A key piece of information. Our conference will be structured into 4 parts. The first consists of 6 lectures, 6 speeches. The second part is a panel discussion, around 45 minutes, just to supplement the presentations, expand on the topic of ICF, about the clinical, legislative implications. And the third part, I believe, much awaited by all the outstanding guests listening to us and watching us now. Mr. Krawczyk has mentioned, representative of the Ministry of Health, of the Center for Assessment of Technologies, and all the other organizations have the possibility of asking questions in our chat. So you will hopefully be able to hand over the questions to our speakers and wait for the answers, if time permits. And then a minute to conclude for each of the 6 invited speakers to sum up and to give us brief recommendations. Now, allow me to introduce all the guests today, all the speakers at our conference. As it has already been mentioned by Mr. Krawczyk, Mr. Nenad Kostanjsek is here, representative of the World Health Organization, WHO officer for ICD-11 and ICF. We are going to talk about this today, so hello. We have here Professor Jerome Bickenbach, who represents the University of Lucerne, the Department of Health Sciences and Health Policy at that university, and at the same time he represents the research branch for ICF. And we will be joined, after some technical difficulties, but hopefully he will join us, Mr. Paweł Wdówik, Secretary of State at the Ministry of Family and Social Policy, Government Plenipotentiary for Disabled Persons, Ms. Elżbieta Neroj, General Counsel of the Department of Education and Inclusion-Oriented Formation of the Ministry of Education and Science, the chairperson of the task force for the draft law for the support of children, students and family, Ernest Wiśniewski, Vice President of the National Council of Physiotherapists, and Robert Jagodziński, Vice President of the Foundation for Active Rehabilitation. So we have 6 presentations. The first one to speak will be Mr. Nenad Kostanjsek. He will talk about the main assumptions behind the WHO Rehabilitation 2030. This is a quantum leap, really, in the initiatives you're going to talk about. The benefits of the system, of the ICF system, the WHODAS 2.0, and the third indicator of health, functioning, and we will talk a lot about it today. And my request to all the excellent speakers, please stick to the time plan for the speeches. 15 minutes for Mr. Nenad Kostanjsek. The floor is yours.
Thank you very much. I hope you can hear me. Can you just confirm whether you can hear me? Okay, great. Thank you very much for this introduction, and it's a great pleasure to join you in this conference with so many important stakeholders present. And as Mr. Krawczyk pointed out, today is the birthday of ICF. 20 years ago, in the World Health Assembly, which is currently also taking place, ICF was adopted unanimously by all WHO member states. And at the time, we were joking among ourselves, saying that, oh, we have here a solution looking for a problem. And I think this is what Mr. Krawczyk also alluded to. And I think we have seen over the last 20 years that the articulation of the problem in terms of the need for functional status information, collecting it in a structured manner, has evolved. And we will come back to that also, I think, throughout these presentations we are going to hear today. So let me start from my side, very briefly giving the context. Now, in the call for action for Rehabilitation 2030, which went out by WHO, you will see that the need for collecting information in a standardized fashion using ICF has been explicitly mentioned. And there's a subsection which talks about health information systems and rehabilitation, where again, you find, as you see here in this slide, a call for action vis-a-vis the inclusion of functioning into health information systems, a rehab information system, and using ICF as a data standard for making sure that you can aggregate and compare the functional status information which is collected. Now, why ICF? What is the value proposition of ICF, in particular from a rehab perspective? Let me just highlight here some of these points. Now, ICF is a classification, and as such, it serves as a common language. It's a Rosetta Stone for functioning and disability information. And as any other classification, it contains alphanumeric codes. And why is this important? Because this helps to transform complex and long text into a code, which then can be aggregated and used for comparison purposes. So this is a very important step and also a point, and I will come back to this in other parts of the presentation. But I think it's important to be clear that it's a classification, first of all. Secondly, as such, it allows to have a structured, standardized documentation of functioning diagnosis, which in turn can be used to inform and to identify needs for rehabilitation, rehabilitation management, the planning of interventions, and the evaluation of rehabilitation services. When you apply it at the system level, of course, by doing that, it will give what we call process legitimacy in terms of making the process fairer, more transparent, impartial, and comparable, particularly if you compare it with the situation of not using a kind of common standard as ICF. Now, in the presentation, we are talking about functioning as the third indicator of health. Now, here in this slide, I put the two other indicators, which is mortality and morbidity. Now, and we highlight the fact that counting and reporting always starts with a code. Now, ICD, as you know, has a long tradition, over 100 years longer, and if you go into the history, even longer. And you see in the slides mortality data coded by different ICD versions. In the second part, on the small screenshot, you see morbidity data aggregated for the global burden of disease studies, and you also find ICD codes listed there. And in the last small picture on the bottom, you see disability survey data, which is compiled in the WHO World Report on Disability. And you will notice, I mean, I think it's very small, but when you go into these surveys, you will hardly find references to codes. And that is at the population level. And it's basically highlighting a kind of issue we are finding across, or challenge which we are still finding in the area of functioning information. Now, I put here a summary of the articles of the UN Convention on the Rights of People with Disability. And you see that in all these areas, you basically need data collected with ICF to do, for example, monitoring of these goals and the respective targets and indicators which result in this. And that is shown here in this one example when you take of the UNCRPD the target on ensuring participation of people with disabilities in political and public life. And that relates to ICF domains, which are clearly coded. But again, the challenge here is that to make sure that the code is used. Now, when you move to the individual case-based information forms, I put here the example of rehabilitation record, which was used in Germany. And you see here the coding of the medical condition, which is listing the respective ICD codes. When you move to the functioning profile itself, you will notice that ICF is used. So there's reference to specific categories. There's also a use of the, let's say, qualifier or the severity of the particular domain. And for environmental factors, there is free text, which you see, which is documented, but which you won't find is the code itself. And that repeats itself through a number of assessment or documentation instruments which are used in a number of countries. Of course, there are also examples where this is now starting to take place. But one of the key messages here I would like to emphasize is that documentation and reporting starts with using the code. And whether it is for the activity or participation domains, or like you see here in this case, for information about environmental factors, or whether it's in the context of work incapacity assessment. And as you may know, in ICF, we can not only do the assessment or the documentation of the deficit, but also the resources, which is, of course, crucial when we are talking about anything which is related to work incapacity documentation. Now, there are, of course, a battery of generic functional status measures used for many, many years, whether they are of generic nature, like you see listed here, ADLs or IADLs, or a whole battery of condition-specific functioning instruments. I put here some examples used for Parkinson's disease. The problem is that sometimes their focus is very unidimensional, so they don't capture functioning as a multidimensional experience. But coming back to the earlier point, the data remains in the silo of the particular instruments because they are not derived or linked nor coded with an international standard or conceptual framework like ICF. So what can be done in terms of addressing this situation and really making sure that we have more and better coding of functional status information? So this is where we are talking about developments also on our side in WHO, in the classification and terminology team, to really improve the access and the use of the classification and the related instruments. And let me elaborate on this very briefly in the remaining time. The basic idea is that the whole process of documentation and coding, of course, starts with the individual record, whether it's a health record, a social security record, etc. And we really have to think how we can make sure that you get to a point where you code once and you use it for multiple purposes and at multiple time points, using the 3 reference classifications, ICD, ICF, and ICHI for interventions together. So this notion of an integrated use of the classification systems, the reference classification with the respective instruments, is really important in that context. And as Poland is also actively working on ICD-11 translation and then subsequently implementation, it's really an opportunity to rethink how the situation can be improved. Now, I just wanted to give you a very quick overview on the ICD-11 related new features because we will apply the same thing to ICF in the process of modernizing ICF. Now, when you look at ICD-11, it is significantly different and better than ICD-10 for a number of reasons. In ICD-10, you had about 14,000 statistical categories, a separate text index, a separate rule base, and there was no link to terminology. The content, of course, was outdated. It's a 30-year-old classification system. And it was basically a system for statistical use, which was imposed on clinicians. Now, this has changed with ICD-11. It is basically a clinical system which can be used for statistical use and many other purposes. And why is this different? Because we added huge clinically relevant detail into the classification through the work we did with many, many medical societies. So what you have now in ICD-11 is 17,000 statistical categories, but underneath you have much more granularity, which is reaching about 120,000 entities and terms. And in addition to that, we are providing an electronic infrastructure which allows to easy access the classification. And just to give you a flavor of these additional aspects, which you also find in ICD-11, is that here in the left-hand side in green, you see the traditional areas. But we added here, for example, a link, and that's a new feature to the ICF and the WHODAS, so in order to facilitate the integrated use. And then when it comes to further detail, there is a chapter which is called extension codes, where you see a lot of detail, whether it is on the dimension of anatomy, laterality. We brought in the histopathology codes from ICD-0. You find medicaments, medical device nomenclatura, the external causes and injury classification integrated, etc. So, and of course, as we also want to make sure that it's easier to use it, we are moving away from a manual system of searching and navigating. And you see here an example where you have the natural language as a clinician would express it, end-stage renal failure. And in order to get to the correct code in ICD-10, it was rather cumbersome and complex to get there, and you needed to have some additional help from tools or rules to make that possible. Now, with the coding tool we have for ICD-11, that becomes a rather trivial exercise and can be even automated. So if you type in end-stage renal failure, you get the same example, you get straight to the correct category in a matter of second. And even if you have more complex statements, like here, the type of diabetes with a complication, you get results displaying a kind of code combination. And that is possible because of these, what we call smart search features, and a whole range of technical things which happen in the background of the application. And of course, in today's environment, where a lot of the health information systems are used electronically, we want to make sure that whatever you can use as an end user in these applications can be also easily integrated into any software application. That's why we are disseminating ICD-11, not anymore as a book primarily. Of course, there's still print copies available, but mainly through electronic means and so-called APIs, application programming interfaces, which are available online and offline using these technologies, like, for example, Docker, Windows services, or Linux system services. I'm saying this because we will basically apply the same infrastructure also for ICF. Now, in ICD-11, we have incorporated a short set of ICF domains to really facilitate the use for documentation purposes. So this is based on the Annex 9 of ICF and the generic core sets to be used in order to generate a functioning profile and to be used for goal-setting, monitoring, or communication across the continuum of care. It is not supposed to replace ICF, but just it's an entry point and facilitating the integrated use when coming to the ICD perspective. We also incorporated for assessment of functioning the WHO disabilities schedule, WHODAS 2. You see here the copy of the Polish version and the features of WHODAS. So it's a clinical scale with well-established psychometric properties, a cardinal measure applicable across all health conditions. It can generate a domain and an overall functioning score, and it has established population norms. And the combination of these features really makes it unique, and you can use it to quantify effectiveness of interventions in the clinical population with reference to general population. We are using it, and Jerome is very much involved in that, in a number of countries where in the context of disability status determination. And we are also working on a WHO case mix DRG system based on ICD-11, where we are contemplating to use WHODAS in order to do quality assurance by measuring functioning outcome in the context of DRGs. So the other important, I think, activity on our side is the modernization of ICF. You see here two pictures of the old ICF browser and the new one in the WHOFIC Foundation. And you notice that we have itemized certain index terms in order to make the search and the access much easier, faster, and more accurate, and not bury those kind of parts in the definition per se. And that will continue. So when we are talking about modernizing ICF, we want to get to the same point as we have for ICD-11 in terms of developing an index and underlying terminology where you can, like in Google search, type in, for example, if you are a rehabilitation specialist, occupational therapist, or whatever, the natural language statement and diagnosis, like monotone speech pattern, and through the index you get to the respective ICF code, the correct one. So we are in the process of enriching this index through the analysis of data sets, and that will be something also to explore, of course, with the different countries in harnessing these data sources, and then working on creating a tooling environment very similar to what I have shown you for the ICD-11. Also maintenance tools like the proposal platform, translation platform. So for example, the Polish translation of ICF, and we are planning to release the updated version later this year, will be done on a new translation platform, and from there also generating the APIs. Now to end with, very briefly, just to mention that there is also the third reference classification, the International Classification of Health Intervention. I'm mentioning this here because it contains a section on functioning interventions, and that has been in the past always a missing element. So there is interest, if there's interest in this particular part, I'm happy to elaborate on this further. In the interest of time, I will not go into the details here, but just as an overview. And let me end with some 3 more slides I'm showing here the population pyramid of Poland, comparing 1970 and the prediction for 2050. And as you see in Poland, like in many other countries, the pyramid is basically flipping. So you see that the population segments in the older age spectrum are increasing, life expectancy is increasing. And the point here is that it's really speaking to the need for a more collection and better collection of functional status data as a third indicator of health. The importance will increase because of this epidemiological transition of aging or even super aging society, increased life expectancies, comorbidities, and so on. We see that you have, as we are progressing and aging, and functioning is part of the human condition, prolonged and alternating functioning. If you think of cancer patients, for example, there's a whole push for personalized medicine, where again, this will give a push again for capturing structured functioning information. And then we have the whole area of big data technology and predictive analytics, which is coming up, which really opens up new opportunities to understand comorbidities and to identify individuals' disease and functioning trajectories and guide the planning and interventions accordingly. So you see here some examples of WHODAS implementation. Unfortunately, one of the pictures here was taken out. Now, this is in the context of disability status determination and evaluation. Some examples in cooperation done with the World Bank. But one picture which I wanted to show you here is also a new application which is currently developed by Apple by integrating the WHODAS 2 in the health app of the Apple software. And there are a number of other big software companies which are also proceeding with this kind of development. So what you will see in the future, that we are looking about having a combination of structured and unstructured data sources. And the importance is that if we want to ensure interoperability between these different systems, the importance of using data standards from the WHOFIC will become more important. And that is whether it be disease information, interventions information, but also functioning information. And this is where the ICF comes into the picture, so that there is really interoperability and the systems can talk to each other, whether you are collecting this information about a particular individual from a social security record perspective in the context of the electronic medical record, or in any kind of smart device or application which are out there. So I hope that gave a bit of an overview on where we are vis-a-vis the ICF in the context of rehabilitation, the value proposition, and a little bit of outlook where we are moving to improve the uptake and also modernizing it to really meet the needs of the 21st century. Thank you very much, and I'm looking forward to your questions and comments.
Thank you very much. Thank you for pointing to some aspects which will most definitely be a subject matter of a panel discussion. Now we are in the presentation part. These IT aspects which have been mentioned by our speaker, they are living a special moment now. The first stage has ended of electronic exchange of medical documentation from the 1st of July. Medical documentation in Poland, electronic medical documentation should be a generally applicable standard. So now Jerome Bickenbach, please tell us about ICF in healthcare, but not only, also about the significance of this classification in the context of the economic advantages which states applying this classification in various areas can use. The floor is yours. Jerome
Thank
Bickenbach.
you very much. I'm hoping that I'm being heard. I'm being heard. Super. I want to actually take a step back after that fantastic presentation by my colleague and good friend Nenad, and ask three very simple questions, because as we enter into this new age and this challenge that Poland is facing, it's nice to have a firm foundation on which to proceed. So I'm going to ask and answer, hopefully, three very, very simple questions. The first is, what is ICF? The second is, what is an ICF tool? And thirdly, what in the world does it mean to implement ICF? So these are my three questions. I should say that our group here for the past 10, 15 years has been involved in actually the very practical activities of turning the ICF, which you have now been introduced to with Nenad's talk, turning it into applications and tools and uses primarily in the area of rehabilitation, but as Nenad mentioned, have also been active in disability assessment, in incapacity for work and other kinds of social policies in which assessment of disability is key, and I'll talk about that briefly. So first of all, just square one, what is ICF? Well, it's very important to realize that ICF is certainly a classification, and that Nenad has spent a great deal of time giving you some of the nitty-gritty details of a classification and its power. The power of ICF, which indeed was what WHO was engaged in when it first proposed it in the late 80s and transforming it into ICF in the 90s, the power is a standard international comparative language. And that is an extremely important activity. It's the sort of activity that WHO is engaged in because its chore, WHO, is to collect comparable information, health, and other information. So the ICF, in one sense, is a classification. Its application in the health domain is as a reference language, as a reference platform, as they call them these days, as a way of coordinating the data that is being collected in a way that allows not only in the electronic mode, but also just the comparability of data across countries, and more importantly, across sectors of each individual country. The sectors typically involved with these issues are obviously the Ministry of Health, but also Ministry of Social Protection, Labor, and other kinds of areas. So merely being able to speak the same language, that is what the challenge that ICF attempted to solve. But for me, there's something more fundamental in ICF, and actually it is a paradigm shift. ICF represents an important evolutionary step in our understanding of what health is. ICF introduces the notion of functioning, and a decrement, a problem in functioning is what we call a disability. But ICF is focused on functioning primarily. But what is functioning? Well, here's one way to understand functioning. Functioning is what matters to people about their health. Unless a person is themselves a doctor, people don't care about their biology. They don't care about their diagnosis. They care about what they can use their health to do in their lives. Can I actually walk across the street? Do I have a mobility problem? Do I have a problem remembering things? That is what matters to people about their health, not their diagnosis, not their biological state. What matters is what they can do or what they cannot do. The domain of functioning is health that matters to people's lives, actual day-to-day lives. ICF entered into the world the third indicator of health, as Nenad put it. We're worried about our mortality, sure. We're worried about morbidity if we're technically concerned about the symptomology of diseases. But what we're really concerned about is what we can do with our health. And that's the domain of functioning. ICF opened our eyes to the fact that when we're interested in health, what we're really interested in is what we can do with it. Now, as it happens, rehabilitation therapists knew this all along, because actually rehabilitation is the health strategy that focuses not on diagnosis, not on cure, but on what people can do with their health. And what we say around here is that rehabilitation is the health strategy that aims to optimize functioning. And that is why, in our context, we spend most of our time in the domain of rehabilitation, because ICF points us there. ICF tells us that what really is a concern in the health domain for people is getting on with their lives, ensuring that they can use their state of health optimally. As Nenad showed, we're engaged now in most countries in the world, and certainly in the eastern part of the world, with dramatic population aging. The pyramids are turning upside down. When we used to have more children than 60-year-olds or 70-year-olds in my category, now we have more 70-year-olds than we have 5-year-olds. And that is a trend which by 2050 will make fundamental differences in how we organize our healthcare and our social policy. But what functioning ICF's contribution to that debate is, now that we've added years to our life, it's time to add life to our years. And what that means is it's time to engage in the fact that people, as they grow older, will inevitably have health declines. But they don't have to have functioning declines. We can optimize functioning even though being older is inevitably associated with more health problems. So ICF is both a classification, a very important tool, and I'll speak about its use cases in a second. But I want to impress upon you the underlying paradigm shift, which is now understood around the world by rehab therapists and others, that when we engage in the practical domain of health care, and when we construct our health systems to actually serve the needs of people, our focus should be on what people can do, the goals they can achieve in their lives, their aspirations that make life meaningful. And that, my friends, is the domain of functioning. That is what ICF is about and allows us to talk about. So what's an ICF tool? Well, ICF itself is not a tool. To be very specific and pedantic about this, ICF is a classification. ICF does not assess functioning. ICF is a vocabulary for assessing function. In order for ICF to be useful in the domain of assessment primarily, what you need to do is to transform ICF into either an instrument like WHODAS, which has been mentioned already, a questionnaire that elicits information from people about what they can do in their lives and what they cannot do or have problems doing. In order to transform ICF into a tool, you actually have to do the work of creating an instrument. But unfortunately, some people think an ICF tool is anything that uses ICF terminology. I see this all over the world. I do consulting in 7 countries, and very often, given the pressure, political and otherwise, to adopt the ICF, the response is to say, okay, we'll use the word body function. We'll use the word activity and participation. And that's what ICF is all about? Well, my friends, what ICF is really about is understanding that health that matters to people is their state of functioning, what they can do with their health. And that revolution, which, as I've said, often takes place most prominently in the context of rehabilitation, is the revolution that should guide us when we're understanding an ICF tool. An ICF tool should be one which understands functioning and tries to capture the notion of functioning as the interaction between a person's biological state and the world in which they live. Because the insight of ICF, the paradigm shift of ICF, something with people with disabilities have known forever, and scientists are only now coming to grips with, is that disability does not exist in a person's body. Disability is a person interacting with their environment. That's disability. A person with a health state may have a problem that's caused by their environment interacting with their limitation and impairments. And ICF gave us that capacity, that conceptual understanding of functioning and disability, which is very important. And once again, it's something which the rehab professions have known all along. If two people have exactly the same impairment, they both have lower limb amputations, but one needs to work in a coal mine, and the other one is a concert pianist. One has a disability and the other one does not. And that's determined by the environment, the demands of the employment, not by the biological state. And that is the insight of ICF. So what does it mean to implement the ICF? Well, that is primarily what we have been engaged in. And one of the things I should mention, Nenad spoke of generic standard classic rehabilitation tools like Barthel and the functional independence measure and the SF-36, and all these tools which have been in the profession for decades. What we have done is made it possible for practitioners to use any tool they want. It doesn't matter at all, because we have provided essentially translation algorithms that transform the data that is collected by FIM, to take one example, or SF-36 or whatever tool you use, and take that tool and translate the data into ICF terms. So at this point in the world, what our recommendation to, at least in the rehab practice, the clinical practice arena, use any tool you like, because whatever information you collect, we can easily transform it into ICF. It's a mechanical, algorithmic procedure involving the transformation of concepts and the recalibration of response options and scales. It's a technical matter which we have more or less finalized. In Switzerland, our primary source of data about functioning comes from SUVA, which is our social insurance company, which is the basis for all occupational injuries and accidents and the source of rehab. They use Barthel and FIM, and we translate all that data into ICF. It is a no-brainer. It's the simplest thing in the world. You don't have to develop specific ICF tools. In clinical practice, you can use the ones that you already use, and you can capture ICF information with them. So that's one component of implementation, and I'm not going to go on much further, but I do want to emphasize the fact that in the domain, in my experience, the domain of the application of ICF that has been the most eye-opening for me. And I must say that I was pleased to be invited to Warsaw in 2015 and then again in 2017 to talk about ICF and what is characteristic of how countries react to ICF is that I was invited by the Ministry of, as I recall, Labor or Social Protection, I forget, and the Ministry of Health was not represented, so there was no communication between the ministries, and I came back to discover that the introductory comments that I had made in 2015 were absolutely brand new in 2018. So one of the challenges of implementing ICF, and one of the challenges that this conference is about, is spreading the word, to be sure, but it has to be spread intersectorially, because identifying the value of ICF in one domain has to be translated to the other. So let me finish with the example that Nenad mentioned, namely the example of disability assessment. As everyone knows, in the context of social welfare policy, social protection policy, disability pensions, sick leave, permanent incapacity to work, in all those areas of social policy, one of the key items, the key steps in this procedure is to assess the percentage or the degree of a person's disability status. And traditionally in Europe, in the indeed the other countries that I've been working with, traditionally that has been thought to be a medical determination. That is to say, a person comes in to be assessed, and a physician says, has an electronic or other health record, you have diabetes. Then they look at a chart, which technically is called a foremic chart, that says diabetes, 70% disabled. This is a medical determination of disability. What ICF, among other things, teaches us is that a medical determination has nothing to do with disability. Nothing. It's useful information for prognosis because some health problems are episodic. Some health problems are progressively degenerative, and you need to know what the life course of a disease is. But if you want to know what disability is, you have to ask people, do you have problems doing your housework? Do you have problems walking across the street? Do you have pain when you walk for a kilometer? That's functioning. So in order to do disability assessment, the medical determination, which is standard in Europe and around the world, is slowly evolving toward an assessment of what disability really is, and that is problems that people have in their daily life with respect to impairments linked to health problems that limit the activities that they can engage in. And the only way to assess that is to use notion of functioning, and in some form or other, we actually use WHODAS a lot because it's a very, very good and robust and scientifically sound instrument for this purpose. But what this showed me was that ICF is a revolution at the end of the day. It's a conceptual revolution. The technical applications in health information systems, in ontology, and the issues that WHO is very concerned about are technical problems for which there are solutions, some of which in my institute we are engaged in. But those are the technical problems. To implement ICF means to change the way you think. All the technical problems, all the magical e-health solutions are not enough. What is essential is to change the way we think. And I've gone on too long, and I apologize. Thank you very much for your patience.
Well, we are deeply indebted to you, Professor, for giving us this very broad expectation of notions of technologies, what is functioning, what is ICF, and what is disability in general. I think this is a good moment to invite Robert Jagodziński to take the floor. Speaking of good practice, we are lacking expertise in this respect and good practice. So ICF in the sphere of professional and vocational activation, that's the main topic of Robert Jagodziński's presentation.
Hello, ladies and gentlemen. I would like to thank the previous speakers cordially for outlining what ICF is and what its role is and in society and how it is interlinked with the other international classification from the family of international classifications. In my brief presentation, I would like to function not so much on presenting the whole picture of good practice, but actually I'd like to look at good practice from the point of view of one of the goals of our conference, namely uniformization and integration of different initiatives and measures undertaken in our country, which are associated with applying the classification in healthcare, education, among other things, but also social policy. So I believe that the target of my short presentation is also to inspire all the guests to ask questions and to discuss these aspects with us. As far as this good practice is concerned, using the classification in the program of vocational activation of people and vocational inclusion of people with disabilities, it was 2010, 9 years after the publication of the classification by the World Health Organization. This was a part of a competition, published opened by the public National Fund for the Rehabilitation of Disabled Persons. There was a project, and the goal for ICF was outlined very briefly. That goal was to measure performance, measure effectiveness of the actions undertaken. So it was a huge challenge for the project to cover the full spectrum of change of actions from the first stage of rehabilitation to its completion to the stage of vocational activation. That was not really inclusion into the labor market, the goal, but actually preparation and giving these people the professional vocational skills. So the project lasted a total of 3 years due to the iterative nature of application of ICF, the whole evaluation and forecasting and intervention planning and final assessment that was actually implemented in annual cycles. A huge challenge also involved the significant diversification of support forms. Support was given often already at the place of stay in the place where the person lived or at the hospital where they stayed. That was also the goals of rehabilitation, also included giving them the possibility of autonomous life and of managing their lives autonomously. So this translated into the model of application of ICF. And the point of view of the participants, well, the participants were actually persons with significant motor organ disability, with spinal cord injuries, but also cerebral palsy, and people at actually at an age in which they would otherwise be occupationally active. So the support covered 3,000 people in total, and that was quite significant also due to the for the selection and definition of the diagnostic map, also from the point of view of the staff involved. The challenge was the novel nature of the classification, the need to acquire specific knowledge, and application of the classification also involves certain formalities in applying it, and the sense of it being a certain kind of mediation of a direct relation with the participants. And it was 2010, but we still had only the working draft, the Polish working draft of classification. Good reference practices were not available. Documentation related to ICF was unavailable. And as far as the national experts are concerned, the situation was not that great. So after the drafting of the first concept, contact was established with the ICF Research Branch, and training for leaders took place. But what is important for all the operators, for the entities implementing the ICF, is feedback. Support at this stage of implementation, deployment. And we used this for a diagnostic map. We used these this extended set. I'll just add, this is for people with SCI, and that set was supplemented by these categories, descriptive categories, the language, the vocabulary for people with spina bifida or cerebral palsy, especially when it comes to this dimension related to cognitive functioning. And at a later stage, separate sets were developed for the social activation program for children, but also totally different ones for vocational inclusion activation. So an abridged set and an extended set was prepared for occupational activation. And also what's important, implementation of the ICF in any dimension is also a competence-based project. So you have to make sure that the staff are prepared. Training for personnel engaged directly in the project took place, but also training addressed to institutions. And as far as medical staff are concerned, also institutional support system was envisaged, and the project also involved cooperation with that. Also, very important, an electronic database, and the previous speakers also mentioned the fact that ICF is a tool for managing information about functioning, and to use this information efficiently, to exchange information, share it, manage it, and share it between different institutions and entities and operators involved in supporting people with disabilities. So this kind of database, this digital database, was indeed developed. And here you have a very brief outline. This is a sheet for preliminary assessment, and here you have a view of the database, for instance, the recognition of the disorder or disease in accordance with ICD-10, but also other information related to health, where information would be entered and a profile of functioning would be generated based on ICF. And what is very important indeed is also something which the previous speakers have mentioned: environmental factors, that is barriers and all sorts of accessibility options, for instance, also assistance and so on and so forth. And so finally, information related to effects of support. Now, very briefly, the advantages. A huge discovery for us was the fact that the whole biopsychosocial model of ICF and the rules of using the classification, they would sort of fit into the existing model of work with people, participants of the Active Rehabilitation program. And I will allow myself to emphasize this. The ICF is not supposed to be a formal overlay or supplement to the existing activity. It's, whether we are talking about social, about healthcare or activation, the ICF actually teaches specialists a certain attitude. It shapes their attitudes in a way. So Jerome has already mentioned it. It teaches a certain approach to health and to functioning also at work of people with disabilities. And the main goal, and what we have talked about, functioning, the main topic. So combining finally these 2 points of view, the comprehensive nature and the customized individual nature of this. So the support should be targeted very precisely on the basis of the evaluation of needs and limitations, constraints of the specific individual. But also this support should be provided in the full spectrum of these needs. Agency, empowerment, this is something that is emphasized very strongly. So the patient's agency, the disabled person's empowerment. We want to look at what is defined as experience of disability or experience of disease. So this treating the patient as an empowered subject, and this is very important in this whole area. And continuity of support provided. This is tremendously important, as in our program, rehabilitation program, we have various projects, and we want to make sure that this support is a certain continuum, is continued. And we want to use all possible resources, those held by the individual, the participant, but also those the institution has access to. The project often covered people who are at the stage of completing the first phase of rehabilitation, and contact with them was at the level of staying in the rehabilitation ward. So also the possibility, the option of communicating on the one hand with the healthcare staff, physicians, physiotherapists, occupational therapists, but on the other hand also possibility of contacting the institutions operating community-based institutions, basically centers helping the family, welfare centers, or even labor offices. And abolishing this, this unidimensional nature. You have people with a spinal cord injury, for instance. You see that this contextuality of support is not only about passing between the services, but also the contextuality concerns a single type of services. So for instance, if someone with SCI in healthcare uses physiotherapist services, or the services provided by an orthopedian or urologist or sexuologist or neurologist, this context of using the service is defined by the ICD-10 code, and often this approach is not holistic, even within a one unit, not to mention the dimension of functioning. So this contextuality should be abolished in this respect. The project was implemented across Poland. Around 400 people were involved in the implementation of the whole project. And these people had different professional experiences, had different occupational profiles. So what the previous speakers have mentioned, the question of language also, translating the specialized language used by experts in the respective fields into a language comprehensible and for everyone, and which can be useful for planning various joint initiatives and a certain approach in terms of team integration. And one more important thing, reporting on the effects. If we have the data gathered in a single database as part of a certain record of a set of resources, then we were able to report such elementary things as disorders related to a neurogenic bladder or to certain other disorders, and we could actually translate it into reports to draw the attention of decision makers in terms of financing of specific services, just how important it is to cover these interventions within the healthcare system, but also in the general dimension. And I'm smiling at Jerome here very widely because and nodding at him, because this function in the full dimension, that was the Polish community-based survey as part of the international community-based survey in relation to people with SCI in different countries, but also pointing to the indicators which should constitute the basis for addressing policies in healthcare, but also in other areas, and experiences. The challenges which you, our guests, may have had in terms of the people involved in using ICF in the practical dimension often involve identifying ICF as a diagnostic tool, as a kind of super tool which is supposed to abolish and replace and supersede all the other diagnostic instruments. But it has to be said quite clearly, and I don't think I have to explain this after what the previous speaker said. The ICF is a tool for the full description of functioning, but it does not replace diagnostic tools. This is quite important, in fact. The challenge related to using ICF in two dimensions, the systemic dimension, that's one thing, when we want to use it in order to create the system for determining certain criteria, certain requirements for access to services or qualification or referral to the services, and the clinical level. So this level of very detailed work with the patient, with the disabled person, this is very important, and the ICF is such a tool because it makes it possible to use information at various levels of detail. But what is important is to set the goals very clearly, our goals in the application of ICF. And by way of example, as part of the program, we were lacking this language, this vocabulary for description, and this was particularly about the chapter related to moving around and mobility. And we started describing information in some working lists on a very kind of general level. You have an example of a code like this here. because we determined that in this clinical, let's put it this way, practice, we needed a more detailed record. So we need to ask ourselves the question, what our goal is in using ICF, and reconciling two perspectives, 2 points of view. One is more philosophical, in a sense, that is looking at the ICF as at a certain language or vocabulary approach to health-related aspects related to function, disability, and well-being of the human being. What is key for humans to function properly in their environment. At the same time, however, complying with some stringent rules in terms of applying ICF, because it is a classification after all, and there are specific rules of applying the classification, and especially the difficulties I would like to point to were related to distinguishing between domains of classification, individual areas related to health and associate domains, and the categories on the other hand. So what the individual classification units are, and you're teaching people how to distinguish between the categories, and recognizing the definitions of inclusion and exclusion. And Jerome mentioned it, that ICF actually shuns specialized language. It actually departs from specialized language. So it is used for communication between different specialists within various systems, but also between specialists from different systems. And sometimes this vernacular definition, for instance, capacity and performance, these are words taken from the vernacular, and they can be misleading. So they need to be actually applied in this quite specialized context in this sense. And I'll give you two examples. For instance, urination control and urinary continence. So this is actually very important. How to put it, because the language may be misleading if we define it in a way which is unclear. And also getting a full description. I chose 3 codes in this case related to difficulties in terms of ocular perception of sight, and also at the level of function participation. We could add a category to get a full description from D7. In contacts between human beings. So that is just combining the interpersonal interactions and relationships, the general interpersonal interactions. So we need to bear this in mind, how to include it in our work with the individual. So this is very important, how we put it in terms of language. I'm not going to go into detail here, but the challenge is also using the qualifiers in ICF. So the whole question of kind of interlinking the diagnostic tools with categories in ICF, measuring disability, measuring the difficulties in functioning, it is important to realize that the ICF kind of returns to simple methods of determination. What Mr. Kostanjsek said about WHODAS, and what Professor Bickenbach said about WHODAS. This is about function and determining it without losing this objectivity and this scientific basis underlying this, and translating diagnostic tools to qualifiers in recording. Some practitioners point to this, that if the identification is at the level of a significant or severe impairment, for instance, then we have to look at the qualifiers. The previous speakers talked about these challenges, and the survey, the disability assessment survey, the WHODAS survey is an answer to this. And the code, the qualifiers, this is not merely a formal record of certain information, but it carries certain information. It renders this dynamic dependence, this dynamic relationship between information. For instance, the capacity and performance example. This points to the need to undertake intervention in terms of community-based factors. So this is broad information, extensive information. And finally, measurement of the effects of support. When we have, for instance, in these joint total questionnaires, we have goals of a certain activation program, rehabilitation or treatment, which are determined at the level of ICF chapters. And the detailed categories defined very precisely by ICF categories are defined at level 2 or 3 of coding. And finally, and Elżbieta Neroj will probably refer to it, the challenges related to using ICF in children. When we were introducing the program into the process of activation of children, that was 2012, social activation of children, and similar difficulties were encountered related to that compared to difficulties in introducing ICF for adults. And the measures undertaken by the Ministry of Education and Science related to the new model of education, relying on Swiss, Portuguese experiences, but this is very important in the case of children, taking into account this developmental perspective. So, above all, in terms of psychomotor development and cognitive development of children, but also the issue of using solutions, for instance, separate sets of categories for children at various age intervals, or using the 9 qualifier. Sorry, Professor. Yes, I'm about to. Sorry, but this is this is the first time I'm actually using this prerogative. But yes, so final difficulty in terms of children, how to distinguish the limitations related from the developmental age and those resulting from health problems. Sorry, I'm not going to go on any longer. Sorry, we could go on for a long time, but we don't want you to enter the sphere which Elżbieta Neroj will discuss. And I would like to thank you for reminding us about one of the most important goals of our conference, namely the need for uniformization, standardization, reporting, documentation. This has been Mr. Nenad talked about the key thing, 3 areas, right? Let's pass to another one, education, because we talked about social activation of disabled persons, obviously the medical aspect, but the word disease has been mentioned, fortunately, quite rarely. We've been talking about health management, management in the sphere of education, management of certain decisions, and this is the topic discussed by Elżbieta Neroj from the Ministry of Education and Science. The floor is yours.
Yes, hello, ladies and gentlemen. I'm going to at least try not to duplicate but supplement what Elżbieta has already said. So thank you for inviting me to this event, to this phenomenon, to this meeting, and share some of my insights in terms of how we managed to deploy ICF and how to actually use it in practice. Now, we've started actually working on that in 2015. Well, 6 years have already passed for us to actually tackle this problem. We have started works on changing the concept on educating students with special needs, including with disabilities, and over the years of various sorts of activities and efforts I'm not going to list, but basically mentioning, I have to mention those very broad, extensive public consultations. In 2019, we've finally worked out and devised a model in which we talk for education for all, which is particularly important from the perspective of the subject that we addressed today, because we decided to apply ICF not only for assessment of the needs of students whose needs have been defined as special, including students with disabilities, but to apply it in order to think how it may actually be used in assessing special or standard needs, educational needs of students in different age groups. Currently, we're working on some specific regulations, specific terms and conditions. So from this perspective, we treat this discussion that I participate in as particularly important because it will have an effect on our insights. We decided to depart from a typical medical thinking and perception on the causes of special functioning. We are per se not a healthcare sector, but obviously recognizing disability or disorder to us and providing some medical certificate actually many a time constitutes a kind of a license, a pass for receiving some special aid in the educational system. So we started works on actually making a practical model, practical scheme based on psychosocial needs in which we consider the psychosocial functioning of young people that is not only dependent on the health condition, but also try to make a lot of people, participants and stakeholders to this process, realize that the condition under which people are educated and brought up may actually constitute certain obstacles and barriers towards their healthy development. Obviously, a long-term goal for us is to prepare them to be independent. Social inclusion, it's another very important goal we are oriented towards. And obviously, another important component of our works was to develop an awareness that the healthcare system cannot independently provide for all the needs, especially those complex needs related to some specific and more serious health problems and conditions. So, pursuing a situation, a coalition in favor of including other sectors in this assessment system, so building a kind of a bridge between individual sectors, was our goal from the beginning. As Robert already mentioned, we analyzed our Polish experience. There wasn't too much of that, well, virtually non-existent. It was before we started working on that, actually, because some other governmental and non-governmental organizations obviously worked there, but they had been applying this classification for some time, but on a non-formal basis. So decided to analyze the needs and experiences that we got in Poland. We thought how to do it on a systemic basis, how to implement this classification and assess how it has actually been used in the educational system. The implementing body was Professor Jerome Bickenbach from Switzerland, to our Portuguese and Italian friends as well. They collaborated with us in this respect. Obviously, we were aware of the fact that we have to adopt this way of thinking and come up with some ideas of how to apply ICF on the grounds of our system. So we worked out certain solutions, specific solutions, and formulated 5 goals for the ICF application in the educational system. Firstly, as already mentioned, data collection of data on the functioning of students, educating people, especially those that are disabled or require certain specific support. We have a lot of information about what sort of support is provided, but we don't really understand what a specific recognized disability means in this context. I'm also talking about the data that concerns some pre-identified barriers in terms of accessibility, struggling with the environment, as well as resources. Namely, what individual healthcare and rehabilitation facilities are in disposal of. Obviously, we have some data on this respect, but obviously we have this suspicion that we are actually in shortage of information from the perspective of long-term planning of education policy. We are lacking this information on how children actually function. Another very important goal is supporting the process of comprehension, of understanding the world and someone's barriers. This is a very important in transition to the psychosocial model. And last but not least, planning of certain activities aimed at improvement of functioning. Unfortunately, in our educational system, those interventions always focused on direct work with the student. And I'm talking about very sort of therapeutic interventions, for instance. And to a lesser extent, they concern is the pressure applied and the emphasis placed on mobilization of certain specific environmental resources. And finally, monitoring the quality of individual interventions and actions. This is yet another element that we consider crucial, especially from the perspective of the current system, in which the efficiency or performance assessment in terms of the support is performed on the level of teacher, school. Sometimes we can speak of some scores in external exams, but they actually provide us with significantly less information on to what extent the given intervention and the support really provided to the given person truly have translated into some specific outcomes as far as the level of skill and competence is concerned, those tested on the external exams. Long-term research on general population of learning children and adults, adolescents is very important because it ensures the right efficiency of interventions. So we started by defining the very notion of functional assessment, and we try to focus not to, consolidate this very medical approach to this vernacular that was already mentioned, this language used under the specific classifications, because it is deprived of certain qualities of functioning. We focused on some psychophysical or mental capacities, and a definition that we developed actually it has been developed by our team, it comprises both information being introduced by different entities based on observations, progress assessments, barrier identification, as well as obviously information concerning the psychometric evaluation of a child or a student. And in this respect, for the functional assessment, it also comprises a procedure that relates to this criterion-based diagnosis, also based on ICD, if a diagnosis has actually been issued. What we stress is that not medical diagnosis or recognition of disability or this criterion-based diagnosis is actually to trigger and activate the support, but the actual problems in functioning. What we proposed was to apply a more practical approach, and we decided to make this assessment more practical in the following manner. Namely, that we proposed that a certain inventory would be developed for individual age groups of students. And in this respect, we've been collaborating with lots of research teams from various higher education schools, conducting various sorts of pilot efforts in the academic milieu, collaborating with students that are engaged in individual classes with children in order to define individual ICF-based categories that enable us to assess very significant spheres of functioning from the perspective of educational support. We propose 2 levels of assessment. First, without qualifiers being applied, namely, which is collect information in individual spheres that are coherent with the ICF, but without applying classification per se, and on such a basis, and based on school-based classifications, trying to generate some measures of support. This is a concept that we've borrowed from the experience of Switzerland. And in this respect, we are talking mainly of the spheres of affective environmental factors and barriers in participation in social life. The other level being that of assessment based on information from lower level, more specialized units and institutions, kindergartens, creches and nurseries, obviously, where we assess aspects of cognitive functionality, personality development, as well as the health-related problems. The target, I hope, will be also something that enables us to gather information that will be used against the ICF and ICD codes as well. What's happening right in our system is something that has already been in progress for some time to develop certain diagnostic tools. They've been prepared since we actually initiated our activities in individual spheres of functioning or domains of function that are more dedicated to specialists rather than to teachers. We also made efforts to prepare such tools in order to prepare teachers for assessment, starting from when they start the obligatory school education, which are supposed to be linked to ICF. This is a way for us to try to demonstrate how results of assessments and evaluations should be translated in some practical conditions and how to use them in this sphere, how from practical perspective we can use the psychometric tools and how to translate them into qualifiers. Anyhow, obviously they are supposed to be tools that are aimed to support assessment in individual domains, and our assumption is that in our regulations or against our regulations we are supposed to prepare some assessment standards in order to give the minister capacity to actually legislate certain specific tools and instruments. We do not really want to focus just on recommended diagnostic tools, but in order to focus on some practical day-to-day solutions concerning how to apply these tools on these levels that I've already mentioned on a daily basis. Now, as far as the challenges are concerned, I suppose there will be time and space to talk about them later on, but for us, and from our perspective, an important thing is to make this process sustainable and balanced, So not only when talking about the assessment of individual child and their adaptation to the environment, but also how to respond to very diversified and disparate needs of individual children in order to make the systemic solutions not to cause overloading of the system, really. We want to really achieve a situation, as Professor Wittenbach mentioned, that we trigger some shift in the mindset and a way of thinking about true needs of children, so that we are not inclined towards, colloquially speaking, doing too much, gathering too much information and simply overdoing what simply should be done. In terms of working with children, obviously, what is also important is that we initiate collaboration between sectors. In this respect, and as previous speaker mentioned, there is a significant difficulty in terms of breaking the barriers in relationships and contact between sectors. What we truly need is a new version and combined classification. By combined, I mean one that combines both adults and children and adolescents in the Polish language, obviously, because if we really want to run efficient policy and introduce this new format of assessment, firstly, we have to create an efficient monitoring system, but also create and develop certain training materials. Materials for training that can be delivered to personnel of different sectors. I hope I haven't gone too far beyond my time. So that's it for me. Thank you for your attention. We really have to move on because the time is running out. We haven't yet had the fifth and the sixth presentation. And I'm giving the floor to President Wiśniewski.
Thank you very much. And ladies and gentlemen, in my presentation, I will try to address clinical implementations. But this is going to be practical, therefore. But to conclude my presentation, I will tell you how we see it more systemically, where rehabilitation can be treated as an investment. So at the end of the day, we're going to talk about finances in a while. But let's start with the facts. The first fact, which is quite significant, is yes, we've got it now. So I'm referring it to the Polish legislation and the ordinance of the Minister of Health. In Article 7, we can read that in the medical records kept by the physiotherapist, the International Classification of Functioning, right, is already mentioned here. The International Classification of Functioning, Disability and Health is considered when describing the state of function. So also the Chamber of Physiotherapists developed some guidelines for physiotherapists for their description in medical records, also for children aged 0 to 7. And these guidelines, what is important, are a certain translation into the language of practitioners of the ICF classification. So we sought to adopt a practical approach to be able to use it in every kind of clinical environment, a hospital, a private practice, or a sanatorium. And also a training program which we embarked on in 2019 was another aspect. The program was interrupted due to the epidemic-related measures in the country, but we managed to hold a training for over 20,000 physiotherapists. This is a third of our occupational group in total. One of the most important elements of these guidelines involved the development of tests related to the individual states of activity, starting with low positions, also sitting down, standing up, carrying up, moving objects, walking around, etc. So everything described in the classification of activity, we sought to select the individual tests and to describe them tests which are easy to perform, which are simple, and which do not require any sort of specialized equipment. Subsequently, we went to the validation program. This was under Professor Czapkowski. This was a large-scale project. 30 researchers in many centers in Poland embarked on it. That was interrupted due to COVID-related actions, but we concluded it several weeks ago, and 82% of the tests actually met the criteria of reliability, so repeatability and compliance, including completely 50% and 32.8% partially, depending on the repeatability and compliance. We also obtained a lot of indications in the program what should be improved to make the tests more reliable. Another important element in the process of implementation, our youngest child, so to speak, is the IT system. So we've talked about IT systems today already, but this is a certain digitization. Finesio is a certain digitization of what we wrote in the guidelines. The application, in a way, takes the physiotherapist by the hand and leads them, guides them in the filling out of the individual elements, also in compliance with the applicable regulations in force. We also included in Finesio ICF codes, but we actually omitted the qualifiers, and we're aware of it. We did it deliberately. Why? Because qualifiers are among the more difficult elements in ICF. From the point of view of clinical practitioners, they are frankly not really well comprehensible, and they don't have this clinical value. So Robert mentioned this indicator related to 50 percentage point of differences. This does not give any sort of clinical information, hence the need to introduce tests, easy, simple to perform, so that we could evaluate every kind of change in the state of functioning of the patient. If someone has a stroke and has problems moving around, walking, we can measure it, speed, distance, fatigue, anxiety, or pain if it's felt. So we have spine problems, pain in a sitting patient. We can measure the activity when sitting down, when standing up, when the pain occurs. We could also combine tests with individual activities with the state of functioning of the patient, because this is the subject of our work. While activity tests enable us to compare patients before and after therapy, we do not have the possibility of using these tests for comparing patients. Now, a certain solution is the WHODAS test, which already has these possibilities. It's validated in terms of comparing many population groups. So we introduced the Polish version of the application, previously validated so that it could be used by therapists. What is important, it already has 10,000 users of the application. This is available free of charge for the therapist. And there are more and more users, but regardless of who performs the test, who does it, and regardless of where the data is obtained, they are comparable across large population groups. I could go on about the facts, but we are short of time, so it's time to pass to the myths. An important myth we have to talk frankly about. Unfortunately, the system doesn't work. It's a myth that the system works. We're actually celebrating the 20th anniversary of ICF. At the level of different organizations, because we've managed to implement different things. This FAR organization, the Foundation for Active Rehabilitation, has been presented here, but these are individual actions. But at the level of the system of healthcare management, ICF is absent. So we have to do everything we can to implement this system into the ICF into the system. Which needs do we see? First of all, we need to change the way of thinking about rehabilitation. We have huge potential which remains untapped, including both human potential and technological potential. We've been talking about a system of accounting, of guaranteed benefits on the basis of the already existing rules. The current system doesn't give us these possibilities. So what if we have the human potential and the technological potential, but if physiotherapeutical procedures are billed for or accounted for, but this is unrelated to other aspects, it's hard to talk about work related to the clinical needs of the patient. Even if we wanted to measure it, we have no possibility of accounting for it, because the system of payments in the refund system does not provide this possibility. What counts is whether the service has been performed, not whether the service has brought yield or return in terms of improving the state of functioning. So this is the need we observe, changing the way of thinking about rehabilitation. Rehabilitation is actually a change of the state of functioning. Another thing is uniformization of the medical record system. So regardless of where the patients start their adventure, whether it's a private practice, hospital or sanatorium, the records have to follow the patients, and they have to be kind of supplement and actually there has to be overwriting of previous documentation. Now every operator has their own system of documentation. We have it is all scattered, but we need to use a single set of tools and a single vocabulary to describe the state of the patient. There are differences, and they will continue to be there because they are necessary in terms of the tools describing the statuses. Depending on the experts, obviously, speech therapists and doctors will use different, other doctors will use different vocabulary to describe their specific field depending on what they do, but this WHODAS is a universal test. Above all divisions, it can actually provide continuity of therapy and uniformity regardless of where the patients end up. Hence the implementation of that into our IT system, of that particular test. And now briefly passing to the summary in terms of the effectiveness. If we can measure the patient's state of functioning before therapy and plan the therapy in accordance with their needs and measure it at the end of the day, we are capable of measuring the cost effectiveness of the procedures applied. And this is the key and the gist of the whole program. And managing therapy time, we obviously say that in hospitals the situation is different. I would like to talk about outpatient clinics where we contract visits in 10 weeks, 10 therapeutic weeks. But I am absolutely certain of this, that the effectiveness of these services would be much better if we could distribute it over time, not in 2 weeks, but 10 visits per 4, 6 or 8 weeks. We lack the data today whether the effectiveness of outpatient therapy is higher if it lasts, every day or every other day or every 3 days. Whether therapy lasting 20 minutes is better than 25 or 30 minutes, but we'll be able to gather this data if we can compare the data in the systems. And in order for us to be able to compare these data, this is what ICF is for. But for this to work, at the systemic level, we need to enter the specific data. Then we'll be able to manage it effectively, to adapt the intensity, the procedures, the time of therapy. But in order for the data to be reliable and in order for this to be feasible, this data has to have a certain quality. In order to have this certain quality, at the end we have the clinical practitioners who generate these data. And what does this mean? Well, the data have to be easily gatherable, so to speak. Well, they have to have clinical value. If we end up with empty tables, blank tables, which do not have any value in terms of the content, then we'll just check, the individual items, but this will have no reference and no validity and relevance for analysis. And this is my message. I would like to thank you for your attention and to like to give the floor to the studio.
Thank you very much. Firstly, I would like to say many thanks to all the speakers for this enormous volume of knowledge that, well, we definitely are running out of time to discuss, that is missing in the discourse. We are going to speak of, I was actually hoping for a lot of questions from the audience, but everybody was so preoccupied with the presentations that I haven't actually received too much of that. The time is running out, but we are trying to be with the schedule. I think 10 past is when we are about to finish in 30 minutes time. So we have specifically indicated certain benefits, advantages of the classification, but also mentioned difficulties in its implementation. Now, the problem of certain specific legislative effort, does it only apply to Poland? I would like to hear from Nenad Kostanjsek as well as from Professor Jerome Bickenbach. Namely, should states actually resort to certain specific efforts, not only to, persuade stakeholders that this system should really be deployed? Would you agree that this is just a theoretical creation, at least so far? Nenad, the floor is yours.
Yeah, thank you very much. Well, to respond to your question, I think we got the answers in some of the points which were made by the previous speakers. From our perspective, we would certainly highlight the importance of creating and pushing and having legislation around standardized documentation of functioning. as just Ernest mentioned for Poland, that the law is now in place. In that respect, however, I would like to highlight the importance of moving beyond rehabilitation. I think it is, of course, as Jerome and others pointed out, I would say the natural comfort zone of ICF, because all rehabilitation specialists and as a profession, this is your day-to-day kind of work and thinking. But I think the challenge is really to mainstream functioning, as we said, as a third indicator of health, particular in the medical field. I think many medical doctors as a profession or nurses, they speak ICF, but they don't, know about it or realize it. So I think that is one important point, how to get, the medical profession on board and really, see that, make them in a way realize, well, if you do an assessment of a patient, actually, you talk about ICF very intuitively, but here's ICF, and it makes it more, structured, and you can be open about it, or if you use WHODAS for that matter. I think having these linkages very practically and being pragmatic and not dogmatic about it, like we have seen in some of the presentations, just the last one with linking the documentation of a particular domain with an assessment test. We did similar things when we did the World Health Survey to really validate and calibrate the response in terms of its severity. I think that is a very good approach, so that those kind of practical things are used will be also helpful to address some of these implementation challenges. And in that respect, the last point to make, and just before that, Elizabeth mentioned about the education. And in that respect, I think, again, making sure that, for example, also medical doctors have ICF in the curricula included, especially the new generation, will be very important. But coming back to the other point I wanted to make is, in addition to legislation, and part of the legislation really has to deal with mainstreaming functioning within the overall electronic medical record or health information infrastructure. And I think in that respect, getting it into, I would say, even more important than electronic medical records or health records are personalized health records, as was pointed out, because that gives the power to the patient, to the client, to the individual. And you look at the evolution of e-health systems, this is what really is changing the entire dynamic. So making sure that ICF functioning information is through ICF standardized and measured then through these measurement instruments within the context of the personalized health record, and to provide legislation in that respect is absolutely critical. And there are, at the level of the European community and within the industry, a number of initiatives underway to do that. And what we see, I mean, even in the context of COVID, that sometimes they are referring to the content standards like ICD, like ICF, but sometimes they're ignoring them. And that is something which really has to be put high on the agenda if we want to be successful vis-a-vis the mainstreaming. Otherwise, we end up being, confronting a kind of fait accompli in having to live with standards or no standards whatsoever in these electronic formats. Thank you.
Thank you indeed. And the same question goes to Professor Jerome Bickenbach. How to convince decision makers, or do we really need to still persuade politicians that this system will actually create certain specific legal legislative schemes as far as medical documentation and implementation? Do we really need to convince politicians about the advantages? And if so, what sort of benefits could persuade them?
First of all, can I be heard? Because I can't. Am I heard? Yes, thank you. In my experience,
yes, we do.
Once again, I mean, I won't rattle off the countries, but my experience is as follows, and sorry about this, Nenad. I don't think legislation is needed. In fact, I have identified several countries in which there's legislation which has had zero effect on the actual implementation of ICF. And I have certainly seen countries, and I will mention Lithuania because I happen to be working there, which is thoroughly implemented into the IT system, ICF, completely, successfully in its IT system. And there's not a word about ICF in any legislation. So the issue is not legislation or not, the issue is successful implementation of a standard. And a country, because of the unique features of its legislative system, its whether level of federalism, and there's a whole collection of factors which would be arguing in favor of the best way to implement. The most successful implementation at the ground level where it really matters, namely in the IT system, is conducted through ministerial regulations or cabinet regulations or something of the sort, much more hands-on. Legislation tends to be window dressing. And it's simply, it's there and countries say, of course we do ICF. Look at that section of the law. It says ICF. And they have, ICF is nowhere present. So the issue is how best to implement. And the answer to that question depends on the situation of each country. The second thing I want to say, and it's also a bit heterodox, Ernest made a
if I may just interject, Professor, if I may just interject, could you please give us a little bit more about the problems in implementation of ICF? Maybe there are some countries we should borrow from and duplicate their solutions. Are there?
Yeah, I'm not going to do that because I've tried it before, and it turns out to be something that it is not very productive, because my experience in several countries now has made it very clear. You do ground up. You don't go top down. You look. I mean, you start at the cultural, the linguistic, the governance structures of a country, and that dictates the way forward. You don't say that there is a plan that. I mean, it's been traditional for the last 10 years to say, look at Taiwan. Well, if you look at Taiwan, it has an incredibly well-integrated ICF system, but it took them 15 years, and they did it in Taiwan, and you can't take that off the shelf and use it anywhere else. You have to do it. It has to be something that is ground up. And what is the most successful way of implementing ICF? I mean, keep in mind my talk. You implement it as a matter of thinking, as a re-understanding, as Robert was saying, of what disability is, what the lived experience of disability is, etc. That's one. That's teachable. And we have training courses that we give and other people give in medical schools and rehab schools and social service and the rest of it. That's great. But if you really want to implement technically, you don't talk to the politicians, you talk to the technicians. And in the IT community, you can sell ICF very, very clearly because of its ontology, or I should say the potential of its ontology. And at the technical level, the efficacy for a technician, when you say comparable, interoperable, they immediately know what you're talking about and immediately see the value of it at that level. Now, you need implementation regulations to get it off the ground if it's a national system, but I don't think that issue should not be politicized because it works much more efficiently as an implementation. Convincing people of the revolution on our understanding of functioning is a communications activity, to be perfectly blunt, and that should be done at the highest level politically and in the public context as well. I had another point, but it's a slightly technical with respect to Ernest, and you may have another direction you want to go.
Thank you indeed. So, speaking of revolution in the mindset and an approach towards ability and disability, towards health and functioning, But I have a question to Robert Jagodziński. What is so specific about ICF that it actually permeates individual spheres, that it becomes intertwined with those spheres of activity? And I'm not just talking about healthcare, we're talking about education, social policies, and, well, we are talking about several ministries, actually. Sorry about that, I'm mentioning politics again, but what makes this system so absorbable on different levels and spheres in terms of Polish physiotherapy and the physiotherapy clinical systems? It is a problem well understood and comprehended.
Yeah, but the question is, who are you asking about? Well, Robert Jagodziński. Oh, I thought so. Okay. Okay, thank you very much. Thank you for this question, and I believe it results mainly from the needs. Because we see on the one hand increased financial outlays on healthcare, on treatment, on services with regard to social inclusion and activation, new schemes, new programs related to interventions into the community-based interventions, and noticing you know what Jerome Bickenbach and Nenad Kostanjsek mentioned, that we have the Accessibility Plus program, for instance, 22 billion budget over a couple of years. We have the Act on Accessibility enacted in 2019. We have programs for activation and inclusion at the level of the regional authorities and central authorities. But the question is, if we have larger and larger allocations, and since we know more, why doesn't it work? Why it still fails to translate into, you know, why we have 1,400,000 people with disabilities who are in an occupationally active age and they have problems with entering the labor market? So the problem is that we don't have you know, the whole process of therapy, of rehabilitation, inclusion into the environment and occupational activation is how to talk about the process. Actually, I could talk about my own experience as a person living with SCI and with 4-limb palsy, and this is something, this is a whole story. This is a set of detached cases, you know, of separate cases. And if we talked about, you know, staying in the different wards and in therapeutic institutions, I am a person with as a quadriplegic person can actually talk about this. These are the critical moments, you know, passing with rehabilitation to your environment where you live, and this can actually be decisive for exclusion or inclusion, passing from education to the labor market. There is this need because specialists work with these services, so they need a platform for cooperation, a vocabulary, a common vocabulary, sharing information. We have increasing outlays, but we need to identify the needs. The needs are being identified among specialists, but also among disabled persons, and but also people who are not interested in how a service is financed. They want to take part in a planned process, a single process. Now a question for Professor Wiśniewski, Ernest Wiśniewski. Now referring to, on a not very optimistic note, rather a pessimistic note, it's not working. I wanted to say that when I was listening to all these speakers and learning about the classification, preparing myself for this discussion, I am absolutely convinced that it's an excellent model. So rehabilitation 2030, can it solve these problems? We have a huge potential, as you said, with this classification. However, it is not that widely used, this classification, as we would want it to be. What has to happen for this to function, Mr. President? I wouldn't like this to echo so pessimistically. Despite the various problems we've encountered on the way, actually, we can say that a lot of things have been done, but there's no systemic implementation. But we have the human potential, so people who are capable of doing this. We have the IT systems, we have the tools in place, we have knowledge and training systems. The only thing is to have it translated into systemic actions. In order for these systemic measures to work, and this is something I said at the end of my presentation, we need to have the medical records are produced by physiotherapists, by specialist physicians, doctors, nurses, psychologists, speech therapists, and so on. So the point is to make sure that the tools we report to the central systems are usable. They need to have clinical value. We as practitioners need to understand what we report on. We need to see the value because otherwise we won't be able to deliver on it. So for 20 years we have not been using this ICF system systemically, because it was over theoreticized. So yes, are we dealing with a new opening, a new beginning? Yes, definitely. So WHO, this third indicator. Well, what a shame it's actually been done so late. Well, late, but better late than never. You know, it's good that it's here for all systems across the world. Looking at the third health indicator, the state of function is crucial today. To plan realistically our healthcare, we need to know not only what people fall ill with, not only what people die of, but also how to measure it. So we come back to the start. So people who work with the patients on a daily basis need to understand our system. We need to simplify it as far as possible, but to simplify it so that it still works. So everything needs to be simplified, but not more than it can be simplified, you know. That's the old adage, but we need to talk about the various systems functioning in Poland, the various social insurance systems. They need to provide this analytical value. Only then will we be able to actually use this system on the basis of these data, because we are talking about millions of data items, data records, which will flow into the central systems. Only then will we be able to see which procedures work and which observations are relevant, what patients really need in long-term care. And planning is not only about medical procedures, but also the whole planning of the healthcare system, also medical staff, the demand for education, the system of education. It all boils down to one thing. So should ICF be taught at medical universities? Definitely, but not as a classification, but as a kind of way of thinking. I believe that the third health indicator should be included in textbooks of medicine at every stage of education, physicians, nurses, physiotherapists, so as to actually explain to aspiring medical professionals how to treat humans, you know, improve the state of function of humans, not only treat the illness or the disease. Yes, it will be hard to build awareness, general awareness of the benefits, right? This is what we should... Yes, briefly it can be summed up this way, but this academic aspect, these aspiring medical professionals, but also people functioning in the medical market today, these medical professionals are responsible for the state of health of the society, of the general public. And they should be ones who understand these data and generate them and transfer them. So this is the role of the media, right? But maybe we'll talk about that at the end. Also industry media, because this is specialized knowledge, isn't it? The ICF is not popular among the average inhabitant of Poland or of any other country. Now, legislation. We have the ordinance in Poland, regulation, right? Since April 2020 about physiotherapy. This has been enforced, but I will ask just a question for Ms. Neroj. In the educational system, do we have a similar? Could we actually use a similar regulation ordinance? Is a regulatory approach appropriate in the approach to ACF in terms of education or the assessment of capacities of students? Do we need it? Yes, by all means, we do need it, and this is what we're working on. We're working on an act at the level of a law which actually should provide this functional assessment and implement it into the legislation in force. But we are aware of this, and I want to emphasize it, that this is the first step, merely the first step. Obviously, creating a legislative framework, this is one thing, but implementation is key to make sure how the classification is used in practice, so as not to end up with a situation in which we introduce a classification with such and such assumptions, very broad and optimistic assumptions, but then as a result, due to lack of knowledge, due to inappropriate application or use, either the data gathered in an unreliable manner or the analysis of the information is not performed in the right way. So in fact, we do not introduce any change in terms of changing the approach we want to achieve. So I'm glad this has been said, that education is key. And I would like to say that there's a huge opportunity, because if we introduce in the educational system, I would just like to remind you that in Poland we can, perform interventions, but we are the educational system, but we can actually provide support at a very early stage, from the child's birth. Actually, we can provide this support. So legislative and organizational solutions are necessary to show how this intersectoral collaboration can go on, and creating a functional intervention plan. For us, the key thing is, and we have already encountered it, because so many years it has taken us. In 2015 we started, so 6 years will have passed soon, and we have this awareness, how much work it has cost us communicating, what the classification is all about, how to use it, because people who had no idea about it at all, teachers, for instance, or other specialists, they would look into that booklet where they have a whole set of codes, information, and they were absolutely terrified. So we should now, about what we were preparing, but now we are preparing systemically. So this is key, I believe, to adapt this message, to adapt this communication related to showing these practical ways of using the classification, depending on who the target audience is. This information is key, in my opinion. It should be generally available. Information related to what the classification is and what it is not, so as to debunk these myths. And we should describe it, we shouldn't describe it with figures only. And digits. This context has actually been mentioned here, and I have to agree with this approach, that it is necessary to implement a system of an IT system, actually, because this optimizes the transmission of information. It shortens the time needed for that. It makes work easier. Work related to preparation, well, there's no other way. Sorry, don't we have a system in place? We have P1, right? We have an excellent system, I mean, an excellent moment to talk about IT systems. Isn't this the area of documentation? Well, yes, but every, I mean, there's a different database and there's a different system for every area. Healthcare has one, we have the educational information system, and so now we need a moment when all these systems come together, communicate with one another, and integrate. And a certain repository is being created, a central register in which these individual systems communicate. I believe this is the future, right, ahead of us? Yes, indeed. This is the way. So this silo has to be silo has to be broken down, and we should break through the silo and integrate these areas. Yes, this will persuade people, because people will find that this really can be done in a simple and concrete manner. This assumption we talked about.
Moving back to physiotherapy, I'm not going to be politically correct. Poland may be a leader in implementation of this legal regulation starting from last year. The physiotherapeutical documentation should include ICF. Well, does it actually meet your expectations? Very briefly, Mr. Wiśniewski and Jagodziński, gentlemen, does this regulation actually meet your expectations? Does it cater to your needs? Yes, indeed, very briefly. I suppose this is a watershed moment where RCF has been actually included in a legal act or regulation, to be more precise. If I may just refer to a broader context and broader picture, this is a dilemma to me. The most important thing, as Jerome and Nenad mentioned, is the mindset transition and preparing grounds for that and trying to build this grassroots pressure. But from a more general perspective, if we're about to reform a system of medical evaluation that is supposed to be based on ICF, there will be a number of problems, and in terms of legislation, far more should be included than, you know, a recommendation to apply ICF. Because if disability identification or assessments or determining the degree of disability, or moreover, determining accessibility of specific healthcare and treatment services and qualification for this eligibility, some part of these matters should be taken into consideration in a law, actually, form. Some of them will be definitely included in information management systems. Some will take the form of a regulation or ordinance of individual ministries. And part of these problems can simply be included in standards of labor of individual specialists. Take the specialization of a physiotherapist. If ICF is included in recommendations of how to collect information, how to issue assessments in other job descriptions for other medical professionals, when we refer to recommendations, acts, legal regulations, it will simply be easier. Thank you very much. Ernest, over to you. Basically speaking, I might say yes, and we are actually proud of this provision because it does create some specific opportunities. It is broad to the point that enables us to actually do a very extensive interpretation. It is an opportunity, but also a huge threat, because on the level of ordinance or regulation, it doesn't provide us with very precise information what should be included in documentation. Hence, a huge role and responsibility of those responsible for implementing regulations and those who draw them up. Just to take those that provide regulations for the co-funded medical services and the institutions that operate according to these regulations. So here's my appeal to all those that are our speakers, guests, but also the audience. Please do not involve practitioners, please do not shun practitioners when creating regulations, because it is us to whom those regulations are dedicated. It's us that will be actually implementing it in practice. What it means in practice? Well, let's create a scheme, a program, let's test it, let's implement pilot program, because every single institution has the opportunity of actually creating those pilot programs. Take the example of solidarity programs where certain funds could be allocated and placed in the market by, for instance, buying certain specific solutions, financing those solutions and putting them into test. I suppose there will be plenty of those programs. They will be coming in numbers, as already mentioned. Just the EU-funded programs that also provide these opportunities. The point is to implement something on a very limited level, proof whether this works or not, and only then translate it into those systems that have already proven efficient, so that we are not users of over-theorized system that doesn't work on the most fundamental level. Well, the theory may not simply actually meet your expectations, and at the very end, and I also ask the studio to give every single participant 1 minute. How to make the path between theory and practice as short as possible. Briefly, guided by the same order. Nenad, Kostanjsek, please.
Be practical, not too theoretical, as already pointed out. Leverage technology, which we have now at hand, which will be really helpful to accelerate a lot of these innovations and to spread it around. And be aware that we talk about always people who are operating the system, people who have to benefit from it. So as we said before, it's about bringing people on board on all sides. Thank you.
Thank you very much for this thought. Professor Jerome Bickenbach, over to you.
Well, I mean, Nenad said it already. I mean, it is very important. All the success stories that I've been aware of have been not because of the voicing of a general acclaim of ICF, but getting people to understand it and to use it at the level that Ernest is talking about, to get it at the level of practitioner, the clinician, the education specialist, and once it is brought into that level through an educational scheme or some other arrangement, then I think the bottom-up approach is always going to be the most successful. and it puts pressure on the governance structures, which can come later to support the adoption of it. So the IT people understand and are completely on board with respect to the value of any kind of data standardization. The practitioners in rehab and other areas are. So I think it's a bottom-up approach is your best strategy. Thank you.
Thank you indeed. Elżbieta, Neroj. Education has been brought to the table many a time today. Very briefly, short recommendation of yours. Deployment, training, dissemination in Polish language of the ICF classification. What I mean is education training courses for different practitioners, different sectors, implementation of an IT system. These are fundamental and extremely practical matters that will definitely help us move ahead. What also matters is to create a scheme of accessibility to permanent training, counseling, and, well, basically to the knowledge. And repetition is the mother of knowledge, isn't it? Ernest Wiśniewski, over to you. Even if you should repeat what has already been said, say it again, very briefly. Our meeting is a good piece of evidence. There is a number of good practices in the country, some that we can be proud of, but what we are lacking is not a need for coming up with a separate, new, novel model of implementation of ICA in terms of rehabilitation, healthcare, but what we're lacking is integration of experiences and making the most of experiences already at hand and trying to come up with this shared model. Working with the patient, with disabled persons, anyway, we will build a single system together. Thank you very much. Ernest Wiśniewski, over to you. Single sentence. Planning, testing, implementation. No solution is perfect at the beginning. You know, Apple hasn't already began by implementing iPhone 10. No, obviously, in order to get to iPhone 10, they had to go through individual stages of development of technology. So we have to be open to criticism and be courageous in pursuing changes. We need changes, we need deploying changes. Let's not be afraid of those changing. Let's implement and test them step by step. Thank you very much. Thank you, everybody. It was a huge honor in the first place to me, but also a huge pleasure to be able to moderate this discussion. Let me just remind you that we're trying to convince all of you that functioning is too serious a matter to let it be managed just by medicine. With all due respect to medicine and people. Our participants in the meeting were Nenad, Kostanjsek, Jerome Bickenbach, Elżbieta, Neroj, Paweł Wdówik, Ernest Wiśniewski, Robert Jagodziński. And the host of this event was the National Chamber of Physiotherapists and myself, my humble self. Detailed reports from this webinar will obviously be released on either Rynek Zdrowia portal as well as on our website. Thank you very much.